Hello, my name's Ben Harris. I'm a consultant in Anaesthesia and Intensive Care at Hampshire Hospitals NHS Foundation Trust. I've had some rather unfortunate personal experiences with anaphylaxis in the recent years, and I wanted to share with you my experiences and what I've learnt. We're going to look at the definition and mechanisms of anaphylaxis. We're going to look at some of the guidelines that are available and the National Audit Project number 6, or NAP 6, that ran about 10 years ago in the United Kingdom. We're going to cover guidance for perioperative anaphylaxis. We're going to look at chlorhexidine. We're going to look at allergy investigation. And then I'm going to talk you through some of the cases that I've been personally involved in. Before we start with my presentation, I'm going to share you my first experience of anaphylaxis. This case was on a routine urology list, and the patient was having a general anaesthetic with a laryngeal mask airway for a cystoscopy. The surgeon requested coamoxiclav for antibiotic prophylaxis. The patient was in his 80s and had had multiple previous courses of penicillin throughout his life without any adverse effects. He went off to sleep with fentanyl, propofol, had a laryngeal mask inserted, and then his anaesthesia was maintained with sevoflurane. Prior to the start of the surgery, I gave coamoxiclav intravenously. Within minutes, there was a rapid fall in blood pressure, which soon became unrecordable. The laryngeal mask airway became very leaky, and my initial thoughts were that this was severe laryngospasm because I was unable to ventilate through it. And he developed a bright red rash and became extremely sweaty with a heart rate of 150. This was quite clearly anaphylaxis, and he was intubated using succinylphonium as a muscle relaxant. He was intubated and the bronchospasm was profound. He was treated with boluses of intravenous adrenaline, and within 10 minutes everything had resolved. The surgery was not urgent, so the procedure was abandoned and the patient was woken up. He went off to the allergy clinic and he had a definite rise in his tryptase, a rise and fall in his tryptase, and skin testing showed that he had anaphylaxis secondary to coamoxiclav. Interestingly, he'd had multiple courses of penicillin throughout his life. This gentleman was in his 80s, and he did report he having a course of penicillin about 2 months prior, and towards the end of the course he described feeling quite short of breath and quite wheezy, but he didn't go to his doctor to talk about this. So this shows it is entirely possible to develop a severe anaphylaxis to a drug that you've been exposed through without any problem throughout 80 years of life. And it shows how quickly it can start and how quickly it can resolve with the appropriate treatment. One of the problems with anaphylaxis is that there are so many different definitions, and what people mean by anaphylaxis varies a lot. There was an international consensus published in 2004, and that international consensus, in the box at the bottom, says that anaphylaxis is a serious allergic hypersensitivity reaction that can progress rapidly and may cause death. It may involve the skin or mucosa, the respiratory system, the cardiovascular system, or the gut. And when it's life-threatening, you get severe respiratory and or cardiovascular involvement, and these can occur without any skin or mucosa involvement. These things in the orange boxes are often thrown around, but are not recommended terms that we use when discussing anaphylaxis. IgE mediated, non-IgE mediated, non-allergic, hypersensitivity, or anaphylactoid are terms that are not used as part of the definition. The definition is a serious allergic reaction that can progress rapidly and may cause death. This next slide provides some more information to clarify exactly what we mean by anaphylaxis. So it's a systemic reaction where the symptoms and signs occur beyond the site of allergen exposure. It usually has multi-system involvement, but can present with isolated cardiovascular or isolated respiratory compromise. Skin signs can be absent in up to 20% of presentations. Reactions occur along a spectrum of severity, and it can be life-threatening. And these reactions can be dynamic. They can often be mild and then get worse, and occasionally they can be persistent or refractory, or even worse, have a follow a biphasic pattern where you think it's getting better and then some hours later it gets worse again. So to really hammer home this point, anaphylaxis is a clinical diagnosis. In that definition, there is no mention of the underlying mechanism. So we're going to call it a serious allergic hypersensitivity reaction that can progress rapidly and may cause death. IgE mediated and non-IgE mediated mechanisms. IgE mediated mechanisms are the classic ones. So this is where you develop antibodies to an allergen. This phase is the sensitization phase and it's clinically silent. But on re-exposure to that allergen, it cross-links two specific IgE receptors, creating a bridge, and that results in mast cell degranulation. The mast cells release profound levels of histamine, tryptase, and other inflammatory mediators that lead to the clinical syndrome of anaphylaxis. There are other ways that this can happen that are not IgE mediated. One can have direct activation of mast cells. One can have activation of basophils, which also release inflammatory mediators. And this area is less well understood, but certainly accounts for some of the cases of perioperative anaphylaxis. We're now going to look at the National Audit Project number 6, run by the Royal College of Anaesthetists in the United Kingdom. This came out in May 2018, and it was a one-year data collection period between 2015 and 2016. All NHS hospitals took part, and every case of life-threatening anaphylaxis was examined. And during that period of time, approximately 3 million anaesthetic episodes were delivered in the United Kingdom. And these are the key findings. The incidence of perioperative anaphylaxis was 1 in 10,000 anaesthetics. And most patients with anaphylaxis that was life-threatening survived the event. Low blood pressure was the commonest presenting feature, and it occurred in all cases during the life-threatening anaphylaxis. 15% of patients with life-threatening anaphylaxis had a cardiac arrest, and treatment was prompt. But when blood pressure was very low, rather than a full circulatory arrest, CPR was often delayed. 3/4 of patients needed admission to the intensive care unit afterwards, but most recovered quickly. And those at highest risk of death were elderly patients with cardiac disease and patients living with obesity. This graph shows the proportion of patients who displayed a particular feature of anaphylaxis at the onset of the reaction. And we can see by far that the most common feature at the onset of the reaction was hypotension, and the second most common was bronchospasm or a high airway pressure. Urticaria and rash really was a very small feature in these cases of perioperative anaphylaxis. Interestingly, there were some other findings looking at the most common trigger for anaphylaxis, and antibiotics were the most common trigger, accounting for 47% of cases within the study. Muscle relaxants were the next biggest group, followed by chlorhexidine, followed by patent blue dye. Interestingly, ticaplanin was a particularly bad antibiotic. They found it was 17 times more likely to cause anaphylaxis than alternatives. And this is important because it's regularly used in those patients that self-report a penicillin allergy. But we know that more than 90% of patients who self-report a penicillin allergy are not truly penicillin allergic. So by trying to avoid penicillin, it might be unnecessary, and you may be exposing them to a higher chance of anaphylaxis with ticaplanin. My second case of perioperative anaphylaxis was rather slow onset. This was a gentleman in his 60s having an open elective bowel resection for colorectal cancer. Anaesthesia was induced uneventfully with propofol and remifentanil and a muscle relaxant. The trachea was intubated, and prophylactic antibiotics according to the hospital protocol were given. In my case, this was gentamicin and metronidazole. The patient went into the operating theatre and the operation started. Approximately 1 hour into the case, the blood pressure slowly started to fall. Initially responding to occasional boluses of metaraminol, it continued to slowly fall over 5 to 10 minutes. An infusion of metaraminol was started, and the surgeons were consulted to see if there was any sign of bleeding. There was no sign of bleeding, and there was no other cause identified The heart rate remained the same, the ECG tracing remained the same, the airway pressures remained the same. There was just a progressive worsening of hypotension. I put in a central line and started noradrenaline, and clearly this is an unnormal, not a normal situation. When the noradrenaline dose was stabilised and the blood pressure was stabilised at a moderate dose of noradrenaline, approximately 0.1 micrograms per kilo per minute, the operation proceeded, and approximately an hour and a half later, the surgery concluded. The patient went to the intensive care unit where the noradrenaline slowly weaned off over the next several hours. The 12-lead ECG was normal and all of his other blood tests were normal. We sent off a tryptase level, or several tryptase levels, and these came back significantly elevated. The patient went to the allergy clinic and his skin testing was positive to metronidazole, which of course he had had multiple times in the past, including during a previous bowel surgery where I was the anaesthetist. So this demonstrates a slow onset, approximately an hour after exposure, of anaphylaxis, causing only severe, profound hypotension. The Association of Anaesthetists of Great Britain and Ireland, along with the Resuscitation Council of the United Kingdom, have recently produced a perioperative anaphylaxis guideline for anaesthetists and intensive care physicians. I'm going to run through this because it is quite helpful and it puts the emphasis on adrenaline. So, the diagnosis, what to look for: unexplained hypotension, unexplained tachycardia or bradycardia, bronchospasm, unexpected cardiorespiratory arrest when other causes are excluded. And it notes again that we've seen before in a previous slide that skin reactions are often absent in severe anaphylaxis. Call for help and stop. Remove the suspected triggers if you can. And the treatment is adrenaline. Intravenous adrenaline, because we should already be used to that given our profession. It talks about 50 micrograms of intravenous adrenaline. And if there's no IV access, one can use the IM doses of adrenaline. And a rapid fluid bolus of crystalloid. Repeat adrenaline boluses, and if need be, start an infusion. And if the systolic blood pressure is less than 50 millimeters of mercury or there's a cardiac arrest, start CPR. So what's interesting here is there's a huge emphasis on early adrenaline. Steroids and antihistamines do not come into this guideline because the treatment for anaphylaxis is adrenaline. And the key message is, if in doubt, give a small aliquot of intravenous adrenaline. This is obviously a very stressful situation, so there are additional notes on the laminated page to give you some other things to think about. So make sure you're giving 100% oxygen. Make sure you have some end-tidal CO2 trace. Exclude an esophageal intubation. Check the airway, check the circuit, because severe or persistent bronchospasm might present with, in the same way as a blockage of the circuit or an esophageal intubation. So you need to exclude these things. The other thing that I found fascinating in this box here, under airway and breathing, in the second line, it says change to an inhalational anaesthetic if appropriate. So that means if you're using total intravenous anaesthesia with propofol, that you should change to an inhalational anaesthetic, just in case the propofol is responsible. Circulation. Hypotension can be resistant, and you often need a lot of crystalloid. It talks about establishing invasive monitoring as soon as practical, doing repeated boluses of adrenaline, and being very quick to start an adrenaline infusion. In my experience, quite often these patients need a second vasopressor, either noradrenaline or even better, vasopressin, which obviously acts in via different receptors to adrenaline, and they'll often need both. Glucagon can be considered if they're on beta blockers. Steroids might help for refractory reactions or shock, but they become way, way down the list after adrenaline and other vasopressors. If in doubt, give adrenaline. My third case of anaphylaxis happened during a gynecology list. The patient was having a laparoscopy with introduction of patent blue dye to assess the patency of the fallopian tubes. The patient was intubated and ventilated. It had been uneventful, and patent blue dye was injected by the surgeon to check the patency of the fallopian tubes. The patient rapidly became quite bronchospastic with very high airway pressures. The patient needed 1 dose of intravenous adrenaline before the bronchospasm broke and the reaction seemed to resolve. This was a very brief, short-lived reaction with an elevated tryptase level afterwards, needing a small dose of adrenaline. And the patient underwent allergy testing, which showed that they had anaphylaxis to patent blue dye. The Perioperative Allergy Network in the United Kingdom have recently come up with a guideline for when to refer a patient for investigation of suspected perioperative allergy or perioperative hypersensitivity reactions. And they recognise that there's quite a lot of variability in referral, but they recommend that you should refer any patient with a suspected hypersensitivity or anaphylactic reaction using the modified Ring and Mesmer scale. I'll show that on the next slide. You should refer them irrespective of the results of mast cell tryptase sampling. So if the tryptase level does not rise and fall, but they've experienced clinical signs of anaphylaxis, they should be referred. But you don't need to refer patients who have a transient self-limiting flushing or those with only localized erythema, for example, to the arm where the drug has been injected. What's really important is that with any referral, you need to fill in the form, the anaesthetic chart needs to be photocopied, there needs to be a detailed narrative of the events, all of the medications, the medical history, and any photographs of any rash. It's also really important to include any documentation from the surgeon and the theatre team when you're thinking about other causes, for example, skin preparations. So this scale classifies the clinical severity of perioperative hypersensitivity or anaphylactic reactions. And you'll remember from the previous slide that grade 1, grade 2, grade 3 or grade 4 should be referred to for investigation of perioperative anaphylaxis. My fourth case of perioperative anaphylaxis was the most severe. The case was a gentleman in his 40s who had undergone multiple anaesthetics in the past with no problems. He was presenting for surgery on the lower limbs and a general anaesthetic was planned. At 23 minutes past 4, I put in an intravenous cannula, and at 25 minutes past 4, I started an intravenous induction of anaesthesia with propofol and remifentanil. I paralysed with rocuronium, and there was a very quick desaturation, and his pulse oximetry trace rapidly became unrecordable. Mask ventilation became increasingly difficult. I intubated him, he was a grade 1 intubation, and initially there was no end-tidal CO2, and it was extremely difficult to bag. It felt like I was bagging a complete blockage in the circuit. I withdrew the tube back to 23 centimetres, I set the APL valve at 70, and I could get some end-tidal carbon dioxide back. It was extremely bronchospastic. The pattern was extremely bronchospastic, and his airway pressures were between 60 and 70 centimetres of water. The blood pressure cuff was cycling but unable to record a blood pressure. I gave 2 mils of 1 in 10,000 adrenaline intravenously. I turned the propofol and remifentanil off and I started sevoflurane. The first blood pressure recording after the adrenaline was at 16:30, which showed a blood pressure of 96 systolic and a pulse rate of 146. It was only then, after he had his circulation restored, that he became very red all over. He needed multiple repeated boluses of 1 in 10,000 adrenaline intravenously, and the blood pressure was maintained, but only with adrenaline boluses. His skin erythema and redness started to slowly resolve, and I started an adrenaline infusion. An arterial line was inserted, and at 17:09 a chlorhexidine-free central line was inserted, and a further adrenaline infusion started. Clearly, this gentleman needed to go to the intensive care unit for ongoing treatment and monitoring, and sevoflurane or other volatile anaesthetic agents are not available on our intensive care unit. He had to be sedated with something, but what was I going to use? I thought about using fentanyl because he'd not received this at the moment. So a trial of fentanyl revealed no reaction. I then thought, well, it must be the rocuronium because the deterioration happened almost immediately after I'd given the rocuronium. So I trialled a slow reintroduction of propofol and remifentanil. I put in a urinary catheter, again careful to avoid chlorhexidine in the gel. But 20 minutes after that, he started to become red again. There was no increase in the amount of adrenaline, but as a precaution, I discontinued the propofol and the remifentanil, and we kept him asleep on fentanyl and midazolam. The redness started to reduce again. We transferred him to the ICU, and the adrenaline was weaned at approximately 2 o'clock the following morning, and he was extubated the next day, feeling very battered and bruised, but neurologically intact. The key investigation that we can perform when we are looking after these patients is the serum tryptase concentration. Tryptase is released from mast cell degranulation, and the concentrations in the blood may not increase significantly until about 30 minutes after the onset of the reaction, and they peak 1 to 2 hours after the onset. The half-life is relatively short, so concentrations return to normal within 6 to 8 hours. So this means that the timing of blood samples is very important. So ideally, the Perioperative Anaphylaxis Network recommend that you should take 3 samples. The first should be as soon as the patient is stable. Obviously, the blood sample must not delay the initial treatment and resuscitation, but it needs to happen as soon as you're able to do so. The second should take place 1 to 4 hours after symptom onset, but the sooner the better, ideally 1 to 2 hours. And the third should take place at least 24 hours after the event. So this is when everything should have returned to normal, and it's this 24-hour sample that is used as the patient's baseline level of tryptase, because it's very unlikely they're going to have a known preoperative tryptase level. What's very interesting is that many laboratories give a normal range for tryptase, but it's not the absolute value that is important for the first and second samples. It's the rise and fall related to the baseline level. And the agreed consensus is that a rise consistent with anaphylaxis is 1.2 times the baseline level plus 2 milligrams per litre. So this means that the peak level may actually be within the so-called normal range that the laboratory provides. But what's important is to compare the peak level with the baseline level, which is the 24-hour sample, and this gives an idea as to how much of a rise you need to call this anaphylaxis. So what do the allergy clinic, the perioperative allergy clinic, do? Well, they start by taking a history and looking at your examination. It's really important that they have all the documentation, photographs of rashes, all the anaesthetic chart and details of any other skin prep and other medication that was given, along with a detailed timeline. There's a number of standardised forms that are produced. The National Audit Project number 6 has a standardised form which provides a structure and several prompts for making a referral. They might be able to do antibodies to specific drugs, often using a preoperative sample that has been stored for a group and save. This might be helpful in working out if a particular drug is the culprit or not. They will be able to undertake various forms of skin testing. They may, if the diagnosis is uncertain, proceed to a graded intravenous challenge, whereby tiny amounts are injected intravenously and the amount is increased whilst observing for a reaction. This is often used to prove that a certain antibiotic is safe or a certain drug is safe, or to exclude something from a process, but it obviously carries a significant degree of risk. Other specialised tests are available, for example, looking at basophil activation tests, particularly important where patients have no rise and fall in tryptase, because we know that anaphylaxis is a clinical diagnosis, and the absence of a rise and fall in tryptase does not mean that it is not anaphylaxis. Below are some common misconceptions or common problems. First of all, previous uneventful exposure, often multiple times. I've seen it several times now that patients can have multiple uneventful exposures to antibiotics, for example penicillin, and then develop life-threatening anaphylaxis after many, many years of safe use. I've seen people say it can't be anaphylaxis because there's no rash or no skin changes, but we know that skin changes are absent in up to a third of cases of perioperative anaphylaxis, and they might only appear when the drapes are removed or when circulation is restored. So the absence of any skin changes does not mean anything. Isolated severe hypotension is the most common presenting sign of perioperative anaphylaxis. It can be slow onset. Usually it's within minutes of the intravenous preparation, but it can be slow onset several hours after exposure, like I found out with metronidazole. Antihistamines and steroids are not useful in the immediate management of anaphylaxis. Do not prioritise these over adrenaline and fluid resuscitation. I often hear it can't be anaphylaxis because the tryptase wasn't raised. Please remember the formula for the dynamic rise and fall in tryptase, and please remember that anaphylaxis is a clinical diagnosis, and not all types of anaphylaxis are mediated by mast cell degranulation, so not all of them will have a tryptase rise. No talk on perioperative anaphylaxis would be complete without talking about chlorhexidine. Chlorhexidine has been described as a hidden menace because it is present in so many innocent creams, wipes, cloths, and lotions within the hospital environment. These are some names that are used within my hospital. Interestingly, the gel that is used to assist in the insertion of urinary catheters often contains chlorhexidine, and many common central lines, such as the ArrowGuard Blue, are coated in chlorhexidine. So it's entirely possible you might put a central line in to treat an anaphylaxis and make it worse, or keep it sustained if that anaphylaxis was due to chlorhexidine. So now we return to that fourth case that I was discussing most recently. It was the most severe one. But what was the cause of his anaphylaxis? It must have been the rock uranium. He deteriorated immediately afterwards, and we know that muscle relaxants are the second most common cause of perioperative anaphylaxis in the UK. I had a very excited phone call from the allergy clinic. This gentleman had a skin challenge test that was positive for propofol. He reacted to multiple different preparations of propofol, and he'd had multiple previous general anaesthetics with propofol. So this was anaphylaxis secondary to propofol, which is quite rare. Propofol anaphylaxis occurs in 1.2% of cases of perioperative anaphylaxis, and it's thought to be due to the isopropyl group or the phenol group. In the past, it was thought that patients who were allergic to egg or soy should avoid propofol, but there's no strong evidence of this. And actually, the American Academy of Allergy have recently stated that patients who are allergic to egg or soy can receive propofol without any special precautions. So that's something of historical note. Thank you very much for listening to my talk. In summary, we have talked about anaphylaxis and how it is a clinical diagnosis. The priority is adrenaline, and to repeat if needed. If in doubt, give adrenaline. Follow the guidelines, use the guidelines, especially in this rare and unusual scenario. Beware of chlorhexidine in hospitals. It's hidden everywhere. And don't forget to send the 3 tryptase samples to aid in diagnosis. Thank you very much. Thank you. Shichiro Taku.